episode of Retina Chats. I'm Hamad Ghunaim, and as always with me, Dr. Mustafa Manhali.
Hello, everyone.
So today's case is a myopic macular hole case. First of all, let me ask you, do you always operate on macular hole cases or when it's a full thickness macular hole? Or do you select your patients? What's your criteria to operate on them?
First, the duration of the macular hole is a very important selection criteria for which case to be operated and which case to need a long counseling about the prognosis of the closure of the macular hole. Also the presence or the absence of macular hole detachment. So in a detached case, you must do the surgery even if the macular hole is not going to close and there is an atrophic
because it's a progressive disease and the whole retina may detach, right?
Probably yes, it's going to detach because if the macula is detached and the hole is still open, the whole retina will detach.
But I mean, is there a certain vision that you, or a threshold that you say that, okay, if I have a vision better than this point, then I won't operate. If it's slower than this point, then I'll operate? I
don't depend on vision, especially in myopia and in macular holes, because this is a very deciding point to count whether to operate or not. So in myopia and with full thickness macular hole, I think the diameter of the hole, the duration of the hole, the presence or the absence of detachment, these are the more important.
Sometimes the duration is not that, you cannot really accurately depend on the patient's symptoms. Sometimes they don't notice the macular hole and you discovered it by accident when they're going to do a cataract surgery, for example. So some patients, yes, tell us that I've been feeling this symptom since a few months or so, then we depend on this. But it's not always, you can't take the patient's word always. So there's no vision that you say that this is a good vision, then I will not operate. Because, for example, this case had a best corrected visual acuity of 0.3, and she was a high myopic patient. So, but for me, she had clear symptoms and clear history that she developed the metamorphopsia and the blurring of vision since about 2 months. So I decided to go for surgery, counseling her about all the possible complications, and she agreed. Okay, let's talk about the surgery itself. Do you stain with triamcinolone in these cases? There's a lot of talking about the vitreous schisis in myopia and the layers of the vitreous. So do you stain with triamcinolone or you just depend on your feeling?
No, it depends on the staining with BBG. And why not triamcinolone in my hands? Because the whitish background of the atrophic choroid will not allow you to find the plane of the vitreous schisis or the remnants of the vitreous easily as in a normal case of diabetes with residual vitreous remnants. So I prefer to do as what you have shown, that you stained with BBG, and I think this is not what you are peeling now, is not an eye lamp.
This is part of the posterior hyaloid.
Yes.
Yeah.
So in these cases, the contrast between the blue of the BBG and the whitish background of the atrophic retina or chorioretinal atrophy gives you a better contrast, so you can peel the vitreous schisis better with the BBG rather than the triamcinolone.
Okay. I as you can see here, I did both. I injected triamcinolone and BBG. Do you use a pinch technique or do you have any other methods to do the initial peel?
For the eye lamp?
Yes.
Yes, I prefer the pinch technique, yes. Pinch and peel, yes.
Okay, so, and in myopic cases, what type of ILM surgery do you do? Do you do a peel or do you have the flap, temporal flap, 360 flap? Here I'm doing a 360 flap, so what's your take on that?
I usually do large temporal flap But in myopic cases, if I don't have a detachment, I do a temporal flap as well. But if it is a detached case, I prefer to do a 360.
Okay, for me, I worry too much about these cases, and I do 360, especially in myopics. But if it's a regular macular hole, idiopathic one, in a non-myopic eye, I can do a temporal flap. So we can see here that there was part of a posterior hyaloid, part of a epiretinal membrane, and then continued the ILM through the other way.
And this is very noteworthy that in cases that you are peeling, sometimes, as you have said, the three layers are cemented together or amalgamated together.
Yeah.
So sometimes when you peel the vitreous cases and you take the whole peeling crossing the fovea, you may inducing inadvertently removing the ILM over the fovea.
Yeah.
So you have to go step by step and assess whether it is an ILM or a vitreous cases or it is an retinal.
So here I found that this is part of not all that I'm peeling is an ILM. There's a posterior hyaloid remnant, so I restained with the BBG, and I found that I removed almost all the ILM. We can just repeat this part. Staining again with BBG here, just to confirm that what I'm staining is what I'm peeling is the ILM. So here there's I couldn't find any more remnants of the ILM, so I just extended the ILM peel and stopped at this. Would you trim like I did here with the cutter the remnants of the flap to just decrease their size, or you just leave it a large ILM flap like this one?
It wouldn't differ if you trim it or not. The idea is not the presence of the flap. I think it's relaxation and increasing the elasticity of the retina, so the macular hole edges can coapt together and started to heal this defect. So whether you trim or not, I think it's about the gas bubble stopping the influx of any fluid inside this hole, giving time for this tissue to start to fill this gap, and to heal and to close the macular hole.
Okay. The point with trimming is that I had a bad experience before that I didn't trim and left it long enough. So during fluid air exchange, these flaps just got sucked into the flute needle, and the surgery was an ILM peel, not an ILM flap. So I just trim it as much as possible so that it doesn't get sucked out through the flute needle. But I know that the aim of the ILM flap is not the flap itself. It's just there's a lot of hypotheses around this, but it's more about releasing the traction. Okay. So for you, this is a gas tamponade, but this case was a one-eyed patient. So would you consider putting silicone oil like I did, or not?
How old is she?
She's in her 50s.
50s, and she's phakic.
Phakic, yeah.
And what about the lens? Is it cataract?
Clear.
Clear,
she was one-eyed. Actually, a monocular. The other eye was lost. It's not lost eye. It's not like an eye with a poor vision. There's no eye on the other side, so it's the only seeing eye.
So I would counsel her and explain the two options: whether to have like 15 days with no vision at all with hand motion, if she has any caregivers that can help her in this period. So I would prefer to add gas to avoid any further surgeries or the complication of silicone, increasing the intraocular pressure, more cataract with the silicone. If she cannot and she needs to regain her vision as soon as possible, especially if you are saying that this patient is an 0.3 vision patient, so she's an active and she's already seeing one. So I would do silicone as you have.
I counseled her and she chose silicone oil, but at the end of the day, we all know that you can push the patient towards a decision, right? If you tell her that you won't see anything for 15 days and you will need somebody to take care of you, and the way you convey the message makes a difference. But for me, I played it safe. I put silicone oil.
So do you feel that there is a difference in the closure rate of the macular hole with silicone and with gas?
I feel that gas is better.
Much better. Right?
Yes, I feel that. Actually, the hole here closed, but still there's a small slit that is not completely closed. The vision, the metamorphopsia improved. Vision didn't improve that much. In retrospect, I would put gas. I think it would. It gives a better closure rate, and these 2 weeks she can just manage, and it's a better outcome overall at the end of the day. So I wouldn't think I would repeat putting silicone oil in just for if the patient is one-eyed. Okay, thank you very much. Hope you enjoyed this episode. Stay tuned for the next one.